Hello, I'm your radiographics podcast host for today, Zach Dell. Welcome to our deep dive on the 2018 AAST Organ Injury Scale revisions for the spleen, liver, and kidney. As fellow radiologists, we know the organ injury scale has a direct impact on how we interpret and report trauma findings. So let's unpack some of the most impactful changes for our practice. But first, let's set some background. What is the AAST-OIS? The AAST is the American Association for the Surgery of Trauma, and the OIS is the Organ Injury Scale. The AAST-OIS is kind of considered the gold standard for grading solid organ damage. It's used everywhere from trauma centers to research studies. Let's dig into the history of trauma grading a bit. The story starts in 1971 with the introduction of the Abbreviated Injury Scale, or AIS. And believe it or not, it was actually developed to improve vehicle safety. So the automotive industry needed a standardized way to assess injuries from car crashes to pinpoint areas for improvement in design. So the drive to make cars safer was the spark that ignited this whole system of trauma grading. The Abbreviated Injury Scale was a breakthrough because it provided a universal language for describing the severity of injuries across different body regions. It's an ordinal scale of 6 categories ranging from minor to unsurvivable. But in trauma, a single injury doesn't reveal the whole story. Patients often have multiple injuries. So in 1974, the Injury Severity Score, or ISS, was developed. This built upon the Abbreviated Injury Scale by dividing the body into 6 regions. A score was assessed to each region based on the most severe injury present, and then the sum of the squares of the 3 highest AIS regions were used. Well, this is a way to quantify the overall severity of a patient's condition, considering all the different injuries they sustained. The ISS turned out to be a powerful tool for predicting survival and has been widely used ever since. So we have the AIS to classify individual injuries and the ISS to assess overall injury severity. When did we start to focus specifically on abdominal trauma? That came with the Abdominal Trauma Index, or ATI, in 1981. And this was a game changer because it was organ-specific and designed to assess abdominal injuries. This was originally for penetrating trauma, but was updated in 1990 for blunt trauma. The risk factor for each organ was multiplied by the severity, both of these being on a 1 to 5 scale, and then summed, ranging from 0 to 200. The ATI provided a more detailed look at the severity of abdominal injury and was the precursor to AAST-OIS. How did we transition to the AAST-OIS? The AAST recognized the need for a more standardized system, something that could be used for research, risk stratification, even billing and coding. So in 1987, they formed an Organ Injury Scale Committee, leading to the first AAST guidelines for the spleen, liver, and kidneys in 1989. So the AAST-OIS was born out of this desire for more consistency and rigor in trauma assessment. And it quickly became the go-to system both in the United States and internationally. But of course, medicine is always evolving, and so is the AAST-OIS. The first major revision came in 1994, focusing on the spleen and liver. They recognized that with the increasing use of CT, hematomas were often managed non-operatively and didn't always warrant high grades. So, they were already adjusting to the impact of imaging technology back then. And they also incorporated Quinault's segmental anatomy for the liver into guidelines. So why was it revised in 2018? Well, the answer is simple. Before the 2018 update, the last major revision was in 1994. So the 1994 criteria was established well before multi-detector CT became the standard. The 2018 update was about bringing the injury scale in line with modern imaging and treatment. The goal was to create a system that better predicts mortality and helps guide management decisions in the age of multi-detector CT. So, what are the major changes and improvements that we should be aware of? Let's start with the spleen. As you know, the spleen is the most injured abdominal organ in blunt trauma and accounts for about a third of all abdominal organ injuries. Over the past few decades, splenic preservation has been preferred and is now the standard of care due to the risk of infections following splenectomy. More than 90% of splenic injuries can be managed non-operatively, and even about 80% of severe injuries can be managed via angioembolization. The biggest change is the inclusion of intracapsular splenic vascular injuries. Active bleeding within the capsule, arteriovenous fistulas, and pseudoaneurysms are now considered grade 4 injuries. Remember, intraparenchymal splenic pseudoaneurysms will follow blood pool on all phases and do not increase in size. On arterial phase imaging, they can look like active bleeds, but active hemorrhage will increase in size and does not follow blood pool. Also keep in mind that AV fistulas resemble and cannot be differentiated from pseudoaneurysms on CT. Because bleeding and vascular injuries within the splenic capsule can often be managed successfully with splenic artery embolization, it's recommended that the spleen be imaged in the arterial phase in addition to the portal venous phase. So, injury inside the spleen is considered grade 4, but if there is any bleeding beyond the spleen or the spleen is shattered, it's considered a grade 5 injury. Lower grade, 1 through 3, injuries are simpler and relate to either the depth of a tear or the amount of splenic hematoma. Only depth of a tear or size of subcapsular hematoma govern the severity of grading these injuries. Hematoma expansion or trabecular vascular injury are no longer considered in the grading system. We're discussing the liver now second, since it's the second most commonly injured organ. But even though it's the second most commonly injured organ, it's the most common cause of death in severe abdominal trauma, with mortality rates ranging from 5 to 15%. A few things jump out at me in these revisions. First, just like for the spleen, vascular injuries are emphasized. Second, in a change I know you will appreciate, is that we no longer need to judge quantosegmental involvement, making grading more practical in a day-to-day setting. And finally, the highest grade of injury is now grade 5. Grade 6 injuries, hepatic avulsion, has been eliminated since it's not a survivable injury and it really didn't make sense to include. Let's discuss a few points about grading and management. For the liver, grade 3 injuries now include vascular injuries with active bleeding contained within the liver parenchyma. Grade 3 injuries also include large, 50% of the surface area, subcapsular hematomas, ruptured subcapsular or parenchymal hematomas larger than 10 centimeters, and lacerations greater than 10 centimeters. Remember though, for the liver, any bleeding outside the liver capsule upgrades the injury to grade 4. Grade 4 injuries also include parenchymal disruption involving 25 to 75% of a lobe or hemorrhage outside the hepatic capsule. And grade 5 injuries, now the highest classification, include parenchymal disruption of more than 75% of a lobe or involvement of neighboring major vessels like the central major hepatic veins or retrohepatic inferior vena cava. Most grade 1 through 3 injuries and some grade 4 injuries can be managed non-operatively. All right, let's move on to the kidneys. For all grades of renal injury, previous considerations such as trabecular vascular involvement or the concept of expansion or non-expansion of hematomas are no longer relevant. Grade 1 injuries include parenchymal contusions and subcapsular hematomas without laceration. As a reminder, renal contusions are ill-defined patchy areas of poor contrast enhancement on portal venous phase that become isointense on delayed imaging, where infarctions will not enhance on delayed imaging and tend to be more wedge-shaped and sharply demarcated. Grade 2 injuries include perirenal hematomas confined to the gerontofascia and lacerations 1 centimeter or less without urine leak. It's important to distinguish subcapsular injuries, which are usually well-defined, from perirenal hematomas, which are usually ill-defined along the borders. since that will increase the grade from grade 2 to grade 3. Also, if there is active bleeding with a laceration or hematoma, that also upgrades the injury from grade 2 to grade 3. Grade 3 injuries include lacerations deeper than 1 centimeter without collecting system involvement. This even includes a renal fracture as long as there is no evidence of urine leak. Grade 3 injuries also now include any injury with vascular involvement, such as pseudoaneurysms, arteriovenous fistulas, or active bleeding within gerota fascia. Active bleeding is defined as focal or diffuse enhancement that increases in size and attenuation on delayed images. Grade 4 injuries include any laceration with evidence of urine leak or extension to the renal collecting system. Delayed imaging can be helpful here to assess collecting system integrity, particularly if there is fluid or low attenuation perirenal collections. Also included in grade 4 injuries are complete UPJ disruptions, segmental vascular injuries such as wedge-shaped infarctions, active bleeding beyond the gerota fascia, and complete renal infarction without active bleeding. An important caveat is that any bleeding must not be from a main renal artery or vein. Moving on, grade 5 injuries include shattered kidneys, main renal artery or vein laceration, hilar avulsion, and devascularized kidney with active bleeding. A kidney is considered shattered when renal parenchymal identification is lost. Remember, a complete renal infarct is considered grade 4 unless there is active bleeding, in which case it is upgraded to a grade 5 injury. The takeaway here is the inclusion of a broader range of vascular injuries in the grade 3 and 4 categories, which can point to a potentially more complicated clinical course. And grade 5 injuries have stricter definitions, which really highlight the severity of those injuries. The 2018 revision of the AAST Organ Injury Scale is giving us a more refined view of trauma, helping us better stratify patients based on their risk of complications. We're moving toward more personalized management strategies. But with any new grading system, it's crucial to validate its accuracy and see how it performs in the real world. And what does the data show? Well, the initial studies have been promising. They suggest that the 2018 revision might be better at predicting the need for operative management, particularly for splenic and hepatic trauma. That's a good sign. It means we're getting better at identifying those patients who will actually benefit from surgery. However, studies also suggest that it might be less accurate at predicting in-hospital mortality compared to the previous version. This could be because of the increased emphasis on vascular injuries, which upgrades injury severity, but is tempered by both early recognition and newer non-surgical methods of treating vascular injuries that could have been fatal in the past. I think it's a significant step forward in our ability to assess and manage abdominal trauma, but like any tool, it needs to be continually evaluated and refined. What else is on the horizon? Well, I think that artificial intelligence holds potential. Imagine AI algorithms that could analyze CT scans and automatically identify subtle injuries or even predict the need for intervention. That would be revolutionary. It'd be like having a superpowered assistant helping us make those critical decisions. And of course, we need to continue fostering collaboration between radiologists, trauma surgeons, and all the other specialists involved in trauma care. Multidisciplinary communication is key. We all need to be on the same page to ensure the best possible outcomes for our patients. I hope you enjoyed this deep dive into the 2018 AAST-OIS, and thank you for joining. It's been a pleasure. Keep those questions in mind as you continue your work, and remember, the world of medicine is constantly evolving, so stay curious, stay engaged, and keep learning.